Welcome to Dental XP. I'm Dr. Maurice Salama, and a pleasure for me today to introduce the speaker for the evening, Dr. Samuel Lee. Dr. Lee is originally practiced in LA, but has moved to Boston, Massachusetts, and he's also a fellow in the Department of Periodontics at Harvard University. And Samuel is going to be speaking tonight on some very, very interesting concepts, new techniques, and evolving and emerging concepts in what I would say is non-invasive approaches to sinus augmentation. And Samuel's been sort of a trendsetter here. I've used some of his techniques and some of his kits in entering the sinus in really atraumatic manners. It has allowed me to do this from a Crestal and Lateral approach. And I believe that you're going to find this to be a very, very interesting and intriguing lecture, something that you will want to review maybe a couple more times and possibly take a hands-on course with Dr. Lee. As a matter of fact, Samuel and myself have a hands-on course in Atlanta that's sold out for October, so it's kind of exciting. We had a very good response to the hands-on program. But next year, we're very proud to announce that we're going to be doing 2 cadaver hands-on courses, one in Boston, Massachusetts, and one in Las Vegas, Nevada. So without further ado, I think you're in for a very nice treat this evening. My dear friend, my colleague, and inventor, Dr. Samuel Lee.
Thank you, Dr. Salama, for your kind introduction. Before I start my webinar, I would like to congratulate Dental XP for doing a phenomenal job on educating dentists all around the world. And I would like to thank Dental XP for bringing all the clinicians all around the world together and sharing our knowledge and experiences. Today, I would like to talk about how to conquer sinus grafting. This is my 5-year-old son, Thomas, and he just lost his front tooth. But he's still smiling because I told him, "Don't worry, Thomas. God will give you a second set of teeth called permanent dentition." When our patients lose their front tooth, we can also, with confidence, say, "Don't worry. We will give you a third set of teeth called dental implant." Dental implant has been phenomenal, providing solutions for people with missing teeth and giving a permanent solution. However, sinus has been somewhat of a challenge, and many people fear lateral window technique. Therefore, there was high demand for inventing Crestal approach, as you can see in this case, because as we know, Crestal approach is less invasive to our patients. One of the most common fear that many clinicians have is arterial bleeding from lateral window. And as you can see, there is a pumping artery coming out from intraosseous bone of PSA. However, this is not really a huge big deal because it could be easily managed by putting a pressure with the gauze or putting some hemostatic agents such as Benecil. Therefore, we should not be afraid of this arterial bleeding, and it doesn't really happen very often. Because I do a lot of sinus lift, many doctors all around the world ask me to come and help them with their sinus complications, and I'll be sharing some of the complications that I have faced in last few years. And this patient, after lateral window procedure, patient developed an infection and constant bleeding from the sinus area. And after 2 weeks, this is the patient, and patient cannot even open his left eye because of infection spreading through the muscle spaces. So what we did was we did incision and drainage and changed the antibiotics to much stronger one to manage, and now he's back to normal, but he lost a lot of weight. Therefore, we should not take the sinus grafting procedure very lightly. This case was an interesting case where patients had previous mucocele around tooth number 14, but the patient was not informed about mucocele. And 6 months later, after internal lift and the implant, obviously there was perforation. Therefore, all the bone graft cannot be seen here. However, patient developed sinus symptom, and dentist was blamed for causing the sinus problem because of implant, which is not true because mucus retention cyst was there from the beginning. But anyhow, when you do a blind technique, this will be the result where you don't know whether you have a perforation or not, and if your implant is sticking up, sticking inside the sinus more than 3 or 4 millimeters, it doesn't look very good. So I don't recommend the blind technique. Um, in any case, I think this case should have been approached from a lateral window, so that you can take out the mucus retention cyst prior to placement of implant. Oftentimes, doctors will try lateral window and ask me to come and help with the perforation, and I re-entered the site 3 months later, and just by elevating the flap, I found Schneiderian membrane already bound to the flap. So just by elevating the flap, there was a perforation, and this can be very easily managed by putting non-resorbable membrane over the perforation rather than using resorbable membrane. Because if you use resorbable membrane and if you wait long enough, the resorbable membrane will degrade, and the Schneiderian membrane and the mucosa flap will fuse together. Then you will make the same mistakes that I have shown you here. Biggest fear that I have when I do a large lateral window is oral-ancillary communication. And when this happens, patient cannot swallow really well, cannot drink the water, and it's really a nightmare. Therefore, I don't recommend opening a really, really large sinus wall. And when you have an infection, you could end up with oral-ancillary fistula, as you can see in this case. So I develop a very easy lateral window technique where you can make nice 7 millimeter diameter window, which is very minimally invasive. This case, implant was inside the sinus right underneath the orbit, and this can be avoided by simply doing two-stage surgery where you do the sinus lift and come back 6 months later to place an implant. Or if you must have to put the implant at the same time, I recommend to achieve very good initial stability. Furthermore, by placing larger healing cap, you can avoid your implant going into the sinus. Now, in my practice, I do not recommend any patients to wear removable partial denture, especially when I do sinus lift and the implant at the same time, so that I can avoid having this type of complication. I hope that I share some of the complications that can arise from doing sinus grafting procedures, and I hope that you agree that we have to keep educating ourselves in sinus grafting procedures. And I am very glad that I have opportunity to meet a lot of doctors all around the world during my sinus courses to discuss and prevent this type of complications from arising. We do have 2-day hands-on course in Atlanta where we do lectures and hands-on cadaver workshop with Dr. Maurice Salama. and I'm very happy that there is a high demand for this course, and our course for next week has been completely sold out. And due to high demand, we did set up another course in Boston and in Las Vegas next year. So I'm looking forward to meeting more great clinicians all around the world to learn about sinus grafting procedure. Let me give you a brief overview of lateral versus crestal approach. As we know, lateral approach, we have to elevate the flap beyond mucogingival junction, and now we are dealing with more basal bone. Compared to crestal approach, we are dealing more with alveolar bone, and our incision is usually within keratinized tissue. Therefore, it is very common not to have much pain or swelling or bruising after doing crestal approach, as you can see on the right side, compared to left side, where we do lateral approach and a lot of incision and flap elevation beyond mucogingival junction. Therefore, many people recommend doing a crestal approach to make it as minimally invasive for our patients. And as I mentioned, because of this artery, many people do feel lateral window, and sometimes, I found very large vessel running on the lateral wall of sinus. In compared to that, crestal approach, there is no artery that you have to worry about in crestal approach. Therefore, many people rather do crestal approach. However, nobody drives with their blind eye. Then why should we do a blind technique where when you do a Crestal approach, you have no idea whether you made a perforation or not? Well, some people say you can have the patient blow their nose and see if the air comes out, which is true. But when there is very, very huge perforation, there's no way you can repair the membrane, and there's no way you can manage the perforation. Therefore, I recommend lateral window technique because you have no guessing. You can see the Schneiderian membrane and you can fully elevate. And biggest disadvantage of Crestal approach is that you need minimum of 5 to 7 millimeter of bone in order to do a Crestal approach. And because Crestal approach is bone pressure mediated elevation, you always have this gap where you always have this dome shape. Therefore, your bone graft material is not touching directly to your buccal wall or palatal wall. In contrast, on the left, lateral window technique, we can fully elevate the palatal wall, therefore maximizing the blood supply to your bone graft. So once again, lateral window technique is much superior in this sense. And we all know lateral window technique, very predictable and very high success rate. So as a young dentist, I always wonder, how can I combine both techniques together and eliminate the disadvantage and have only the advantages of both techniques? And that's why I developed this technique called Crestal window sinus grafting. And it is really important to understand this technique fully so that you can maximize the benefit to your patient. And I have designed many tools and small instruments to really maximize this technique, which I will be showing you in the 2-day hands-on courses with cadaver. This technique is great when you do through the socket. You don't even have to elevate the flap after extraction. You can, as you can see here, you can fully elevate the palatal and buccal Schneiderian membrane, and by placing super wide diameter implant at the same time, you don't have to worry about closing the flap. And 6 months later, I restored the case. In contrast, if you do lateral window technique, after the bone heals and so on, it's going to take you more than 1 year to complete the case. When you do multiple site, here patient is fully edentulous with only 1 millimeter of residual bone height. This is the perfect case to do Crestal approach because it's a full mouth implant case. You don't want to lay a huge flap for a long time, exposing bone to oxygen. Therefore, by making a very minimal of palatal incision, we can have a nice set of windows through the crest, and you can take your time to elevate the Schneiderian membrane. Once again, as you can see on the right, it's not a blind technique, and you have a full vision of a Schneiderian membrane when you are lifting the sinus. And you can, even if there is a tear, you can manage the tear because you have a multiple window. So in a sense, this is like doing a lateral window. Only thing is that it's a Crestal approach. Therefore, I named this technique Crestal window technique. And we were able to elevate 14 millimeter and put 10 millimeter implant. And patient received the full mouth implant with bilateral sinus grafting through the socket. And most importantly, on the CT scan, as you see here, is not a dome-shaped bone graft. And my bone graft fully touches the buccal wall and the palatal wall, therefore maximizing the blood supply to my bone graft. This is possible because of this specialized diamond drill that we created, where it cuts the bone, but it does not cut the Schneiderian membrane. And this is because of a special simple formula: pressure equals force divided by area. Therefore, when you have a burr with a pretty much large surface area, you will put very minimal pressure to your Schneiderian membrane. And as you can see in this egg, I was able to drill through an egg in less than 3 seconds, yet none of them got perforation. Getting a nice access to the sinus now is very predictable with this simple diamond drill. And in my course, we have this contest where the doctor who makes the most number of holes in 30 seconds wins a large prize. And on average, most doctors will typically make 10 to 11 holes without any problem. Now, this doctor from Atlanta, he holds the world record, 17 holes in 30 seconds. So, very, very easy technique.
Sinus lift kit is just the best. It's atraumatic, it's simple, it's easy to use. I mean, I access the sinus and I think about probably 2 or 3 minutes maximum. Did a nice sinus lift. It's done really quick. I mean, you guys got to try it. I mean, again, there are other systems out there. There are other classes. When you take those, then you take this. But if you take this, you're never going to go back. Okay? Trust me.
Thank you, Dr. Lin from San Jose, for giving excellent testimonial. And he did a nice internal sinus lift and 4 implants. Back in 2009, I presented this new classification of sinus anatomy. With this classification, we now can have new treatment approach for individual sinus cases. When you have a class 1 sinus anatomy where you have a very wide buccolingual dimension such as 12 millimeter, and when you have relatively high bone such as 7 or 8 millimeter of initial bone height, why even do lateral window or even a Crestal technique when we can put short and wide diameter implant such as 7 millimeter by 7 millimeter? Then we can avoid a lot of unnecessary sinus grafting procedure, therefore making it minimally invasive for our patient. Now, when we have a very pneumatized sinus and when we have a relatively wide bone, instead of opening lateral window, we can open Crestal window. Oftentimes, through an extraction socket, you have a very wide bone And instead of opening a flap or even opening a lateral window, why not just make a Crestal window through the socket and put the wide diameter implant to seal the socket? Now, when you have a relatively thinner bone and when you have about 7 or 8 millimeter of initial bone height, we want to expand the ridge. At the same time, we want to bump up the sinus 2 to 3 millimeter. Then let's use osteotome technique to expand the bone at the same time to bump up the sinus a little bit. And lastly, class 4 sinus cavity would be a very thin sinus and severely pneumatized sinus. In this case, I recommend lateral window technique to make it as predictable as possible. However, as I mentioned earlier, most people fear lateral window, so I introduced very simple lateral window technique called bottle opener lateral window technique. Here, this is as easy as opening a beer bottle. Simply, you use a specialized trephine to make a groove on the lateral wall, and this trephine have external stopper so that you're not cutting into the Schneiderian membrane, and we will use specialized window opener instrument to engage this bone and pry out of the lateral wall. And oftentimes the doctors who come to my live surgical course, they will make 2-3 windows because it is so easy to make a window. It takes less than 2-3 seconds. And here in this video, I will show my doctors making, my attendees in my live surgical course making multiple access to lateral window without spending not more than 2-3 seconds. Sometimes you have to be careful because the sinus wall will fly out. Here, luckily, it got cut on the lip. So as you saw, it's very easy to open the lateral window, and you can do it in very controlled manner. The best part of this technique is that you can later on put this window wall back, therefore preventing any epithelial migration into the sinus.
Sandy's science kit is a very special. I mean, you must have spent a lot of time. I've been to oral surgeon's sinus lifting course, and it was very complicated. So I was very frustrated. I decided to drop it. But since I came to Sammy, his kit is very simple, very easy to learn. Anybody can do it. Fantastic.
Thank you, Dr. Wu, for giving a nice testimonial. In the next 30 minutes, I would like to share with you 2 cases. One case involving lateral window approach, second case involving Crestal window approach. The first case is a lateral window case. Whenever possible, I like to do Crestal window because it's simply less invasive than lateral window approach. However, in this case, patient had a tooth inside the sinus. Therefore, I needed to remove the tooth from the sinus and then do sinus augmentation and implant placement. Therefore, I needed to open lateral window for better access into a sinus. Simply, Crestal window is too small to be able to remove a tooth. So she has been missing upper left molars for more than 20 years, and she's been chewing only through her right side for almost 20 years. And we can see the shift in uh, her occlusal plane and also her eye level. And oftentimes people who has been missing unilateral or has been chewing only through a unilateral side, you will have a different development in the muscle on the jaw closure. So you will have facial asymmetry. She had a very deep bite, therefore it was critical to place posterior implant to increase the vertical stop. At the same time, we needed to splint the crowns together for the implant to avoid any unfavorable force. And as you see in this panoramic x-ray on the left, she has the tooth inside the sinus, and also a wisdom tooth was present on number 16, which was trim implant to be removed. On the CT scan, her sinus shows very clear sinus, very healthy sinus. However, once again, there is a tooth attached to the floor of maxillary sinus. So whenever I take a CT scan, I look at few things. Number one, patency of natural ostium. Number two, thickness of Schneiderian membrane. Here, relatively thin, but very healthy sinus. And mucocele or polyp or any other pathology should be notified, and appropriate consultation to ENT should be done. And the location of intraosseous anastomosis is a very critical thing, because I don't want to have any complication with ecchymosis and so on. And the thickness of lateral wall and buccolingual anatomy is critical in deciding which approach you go, whether you go lateral or versus Crestal. And whether you have a septum or not will be also very important aspect to look at. So I like to lay very minimal flap here. I went probably 1 or 2 millimeter beyond mucogingival junction, and beyond that, mucosa tends to be very flexible, so you can really elevate a lot. And tooth number 16 was removed because it got in the way of placing an implant on tooth number 15. So first step is to use 7 millimeter diameter trephine with the 0.5 millimeter stopper, and simply here our goal is to just mark the bone with the trephine without penetrating the maxillary sinus. So as you can see, this trephine has a very short shank, therefore it doesn't really get on the way to the cheek when you do this procedure. Now this trephine is flat, however sinus wall is never flat. Therefore this movement, this rotational movement of handpiece is very critical to make a complete groove all around the sinus wall. And this simply takes about maximum 4 or 5 seconds to do. And here we want to use the window opener to pry out this pre-drilled lateral wall. And posterior to this window location, you can see trace of this small arteriole running across the lateral window. So after the trephine, we will use the window opener to pop out the sinus wall. Here I'm beginning to put it in on the inferior portion, and you want to have a nice grip of this sinus wall. Here it's moving, but I don't have a nice grip. So I go to the distal, I try to elevate there is actually less movement than inferior. So I go to the medial, I try to do the same, and it moves, but it's not as nice grip as I want. So I go to the superior. Now I see the bone move a lot, and I got a nice grip of the sinus wall. So I will further elevate, and simply you can pop out the sinus using this specialized instrument called window opener. It's like a bottle opener. And simply all you have to do is grab the window because it's already detached to sinus wall. Okay, so now we have a nice Schneiderian membrane exposed, and you can see the small arteriole running into the Schneiderian membrane from posterior to anterior. Once again, even if you tear this arteriole, it's not a huge disaster because it could be easily managed by putting some pressure with the gauze or using a product like Benecil. So you want to do initial elevation with mushroom elevator. So this instrument looks like a mushroom, and you simply want to go around 360 degrees, detaching the Schneiderian membrane. Okay, so this is very simple. And next step is to use my curve elevator. And this has a nice curve, so you have a nice approach to the mesial and the distal and the palatal. And the key here is that your tip of the instrument should be always touching the bony wall. If the tip is touching the Schneiderian membrane, then it's more likely to tear the membrane. So always the tip should be touching the Schneiderian membrane, and you want to walk. Actually, always the tip never should touch the Schneiderian membrane, and you always want to do a bone mapping with the tip of an instrument. Next, you want to use more straighter elevator. I call this palatal elevator because it really allows you to lift all the way to the palatal side. Now here I have a tooth that is actually bound to the sinus floor. So I felt a lot of resistance, so I'm going around the tooth trying to elevate the Schneiderian membrane. Okay, so when patients breathing in and out, I could see the tooth almost through the Schneiderian membrane. So I decided to lift furthermore and then remove this tooth. So there is a tooth in below the Schneiderian membrane, and I was able to remove this tooth without tearing the Schneiderian membrane. It was actually below the Schneiderian membrane, and this is how the tooth looks like. So now all I have to do is remove the tooth from the sinus, and simply I use the pincet to grab and remove the tooth. Okay. And when I have the patients breathe in and out, you can really see the palatal wall. You should be able to see the palatal wall because we want our bone graft to be touching the palatal wall. So if not, further elevation of Schneiderian membrane is recommended. So here I'm going to make implant osteotomy after membrane elevation, but it's important to make osteotomy for the implant prior to bone grafting into the sinus. It's because when you use irrigation to prep the osteotomy, all the bone graft will be lost because of irrigation. So I'll be using Megagen's Easy Plus implant fixture. So first I'll be using lens drill to mark the implant location, and implant is all about location, so making the first drill is probably the most important part of this procedure. So you don't need, even if I'm putting a 11.5 millimeter implant, 11.5 long length of an implant, I don't need to drill all the way to 11.5. I just need to penetrate through sinus floor. So that's what I'm doing, and I'm using 2.0 twist drill to further enlarge, and I'm just lifting the Schneiderian membrane and making sure that it's protected away from the twist drill. Due to the limited time, I will skip implant osteotomy. I will pack bone, and simply I will mix the bone graft material with blood, whole blood, and it tends to coagulate together. Therefore, it's much easier to handle, and my assistant will handle that for me, as you can see in this video. And all I have to do is just condense the bone into the sinus cavity. You typically want to put about 2 cc's of bone in this size of sinus, and it is very critical to condense the bone mesially and distally with this spreader. So it is very important to condense the bone. You could never over condense the bone because number one, it's mixed with the whole blood, and because it's a sinus cavity, you can never over condense. So I will skip some of the unnecessary video due to limited time. And you want to insert the fixture, and it's really important when you insert the fixture not to use any irrigation. Number one, because patient is in supine position, so we don't want to introduce any more irrigation than necessary. And also, if you really notice, the shape of the implant fixture is slightly wider at the crest versus the body of the implant. This is very critical, because we want to get really good initial stability from just the crestal portion, because this patient only has about 4 or 5 millimeter of initial bone height. So it is really important that the platform of the implant is slightly larger in diameter compared to the body of the implant. And slow insertion, as you can see here, is very critical in order to avoid heating of the bone, and also allowing bone to expand. I like to put this fixture slightly deeper than external hex implant, simply because of platform switching and internal connection. Okay. The next implant will also be inserted, once again without water, and it's very slow insertion is very, very important. So due to limited time, I will go ahead and skip this, and I have put the cover screw with very good initial stability. If there is lack of initial stability, you want to put a slightly larger implant to regain the initial stability. So this autogenous lateral bony wall is going to be placed back into the lateral window. And before I do that, I like to put more whole blood because I'm using this blood clot as a glue to stabilize the lateral wall. So I will simply use the whole blood, which is partially coagulated, or you can use a product like Benecil or PRF or PRP with a lot of thrombin. But I like to use whole blood. So simply we put the window back. Okay. And then we will just make simple sutures. So this is right after the surgery. You can see the shape of the root because the membrane was not torn. It will reproduce the original shape. And we have placed about 2 cc's of bone graft. In fact, I placed more than what I like to place. I like to place slightly less than this, just enough so that the implant is not sticking out into the sinus. And I have placed 2 Easy Plus implant. This is 1 year after loading. Patient is very happy because I was able to finish this from start to the end in just 6 months. Now the second case is a Crestal window case. And once again, I always like to use Crestal window whenever possible, but you have to meet two requirements. Number one, buccal lingual dimension must be wide enough in order to make wide window through the crest. Bigger the window, the easier it will be. So extraction socket is a perfect scenario, or people with brachyfacial square face, such as you see here, you will have a very wide bone. If you have a dolichofacial patient, then you will have a narrower buccal lingual dimension. So this patient came in and she was referred by an endodontist, and endodontist told me that she had a root fracture on tooth number 3, therefore it cannot be salvaged. And she was very scared of coming to the dentist, therefore she said she would like to have a minimal pain as possible. So once again, her mandibular plane is below 27°, very deep bite, square face, therefore we need to put wide diameter implant such as rescue implant, 7 by 7 or 6.5 by 10 or 8.5. So once again, she has a very square face and heavy occlusal force. And we have about 4mm or 5mm to the sinus floor. So as soon as we extract the tooth, we know we will have a Schneiderian membrane exposed or very close to it. Therefore, a Crestal window approach will be the most ideal technique for her scenario. And once again, it's tooth number 3, and you can see overall her occlusion relatively a lot of wear and a lot of occlusal force. Her Schneiderian membrane was somewhat thickened, which makes the Crestal window more favorable, more predictable, because we gotta put a thick Schneiderian membrane, and her sinus is pretty clear. Her natural ostium was patent. There was no sign of mucocele, no polyp, and location of intraosseous anastomosis or PSA can be seen here on the buccal side, which is very small in diameter. Oftentimes you will see much bigger than this, but it doesn't matter because we're going to open window through the Crestal direction. And thickness of lateral wall and buccal lingual anatomy is also critical. Once again here, because it's an extraction socket, we have a pretty wide buccal lingual dimension, therefore making Crestal window technique more favorable. And there was no septum present. So first thing is atraumatic extraction. We don't want to break the buccal plate. We want to slowly expand the bone and maintain the buccal plate. And best way to do this is use the luxator between PDL to luxate the tooth. And you want to put this very thin luxator between the socket, trying to luxate, or you can use piezoelectric to loosen the PDL and help elevate the tooth. So I will use this between PDL. After I do that, I will use forceps. Here we have an Asian patient, and from the preoperative x-ray, we saw the root was relatively short. Therefore, I didn't really want to section the tooth because I felt confident that I can take out the tooth without breaking the buccal plate. But if I have a relatively long root, and then I will section the roots in 3 sections and elevate the roots and take out each root separately to preserve the buccal plate. Once again, here patient has a short root and relatively straight, not much curve. So I will slowly use the forceps to expand the bone and then extract the tooth. So here I'm putting a constant pressure towards the palatal and constant pressure towards the buccal, and you really want to feel the curvature of the root, because the curvature will tell you which direction you should take out the tooth. You should never go against the curvature because then you will break the root or you will break the buccal bone. Either way is not good to place an implant. So atraumatic extraction is very crucial, and slow extraction and preservation of buccal bone is very critical. So once again, Asian patient, Korean patient, so very short root, and we were able to extract the tooth in very atraumatic way. So we have a very nice septum here with a very nice buccal bone, and we want to probe and we want to explore this buccal bone, and I like to use endodontic instrument called a Glick instrument by Dr. Glick, and I'm using this see uh, to see whether I have an intact buccal bone and to see if there is any Schneiderian membrane exposed. Fortunately, there was no Schneiderian membrane exposed, and there was nice buccal bone intact. So now you want to use pointed trephine, and this trephine has a lens strial on the center, therefore it will prevent you from wobbling all around the place, and you want to use 1000 RPM with irrigation. And as I mentioned earlier, implant is all about location, location, location. So you must do this in the right location, or your implant crown will not look very nice. So I am using a lot of irrigation with 1000 RPM, and you just want to go to the black mark, which is 2 millimeter. Our goal here is to just locate our location of next trephine. So that's what I did. Now the second set of trephine is called ASBE trephine, stands for adjustable stopper and bone ejector. And this trephine, you want to go 1 millimeter short of sinus floor. So here we have about 4.5 millimeter to the sinus floor from septal bone. Therefore, I set the stopper in about 4 millimeter, and so that I don't drill longer than 4 millimeter, and the stopper is located inside the trephine, so it's an internal stopper. After I set the stopper, I will use a very low speed without any irrigation, and you want to slowly advance the trephine, going 1 millimeter before the sinus floor. So once again, there's no flap elevation is after extraction, and we are using the extraction socket as our Crestal window. Next will be removable of this septal bone. Oftentimes it will come out inside the ASB trephine if the bone height is more than 5 or 6 millimeter. But in this case, the bone height is so shallow, it did not come out with the trephine. In that case, what you want to do is you want to use any curved instrument to elevate this bone out. So simply, I recommend using a curved instrument against the palatal wall between the trephinated bone, and you simply want to elevate and try to break this septal bone away from sinus floor. So that's what I'm doing, trying to place this between the bone and trying to break this septal bone. So here I was able to break the septal bone. So now all I have to do is pick it up with tissue forceps. So I will pick up the septal bone with the tissue forceps, and here you have to be kind of gentle because this bone is oftentimes attached to Schneiderian membrane. Now it comes diamond burr at our magic diamond burr with large surface area at 1000 RPM with a lot of irrigation. You want to use ample amount of irrigation to prevent hitting the bone, and you want to allow the irrigation to touch the bone to prevent any overheating of the bone. And after you use this, you want to take it out and you want to observe whether you have a nice Schneiderian membrane. In this case, we have a nice Schneiderian membrane exposed, and now rather than grinding furthermore, we want to use a set of mushroom elevators to further elevate the Schneiderian membrane and detach the bone away from Schneiderian membrane. So here I have a 4 set of mushroom elevator, and you want to slowly elevate, identify the edges of a Crestal window, and please remember that sinus is never flat and you will have a slope. So you want to respect that and use the instrument appropriately. And I will use next set of mushroom elevator to further elevate, and I will use Cobra instrument to further go deeper into mesial, palatal, and buccal. And this Cobra instrument is very delicate instrument, and it has two curves. Therefore, it will really allow you to advance much deeper than you really can. And it is very critical to know that when you have very low pneumatized sinus, this elevator can really go inside the sinus throughout the sinus cavity. However, when your bone is 7 or 8 millimeter away, you will have a difficult time using this instrument getting access throughout the uh, sinus cavity. Therefore, the easiest case for Crestal window technique would be the cases that have a very pneumatized sinus, such as 1 or 2 millimeter of residual bone height. So now we have a nice Schneiderian membrane exposed, and you will see membrane moving up and down. And simply all we have to do is we ask the patients to breathe in and out, and you will see the movement of Schneiderian membrane. So here we pack the bone and we insert the implant. So here I'm just packing the bone, just using FTBA. And after I pack the bone, I inserted implant very slowly without any irrigation. And here we are using wide diameter implant called rescue implant manufactured by Megagen. And this is I think it's 6.5 by 10 millimeter implant. And slow insertion is very critical. And in extraction socket, I like to place implant a little deeper than usual. So I like to place this implant 1 millimeter below the buccal bone, and that would translate into 4 millimeter from buccal gingival margin. And because this implant has a platform switching, deeper you place, you will have a much better time when you restore in terms of controlling your emergence profile and so on. So after that, we will seal the socket by using wide diameter healing abutment, in this case 8 millimeter healing abutment, and this will pretty much seal 90% of the socket. And after that, we will use suture to further compress the gingiva to achieve 100% of socket seal. And you should put healing abutment only if you have greater than 20 newtons per centimeter. If you have less than that, then I recommend using either open membrane technique or raising flap to get full coverage. So this is after suture. You can observe that socket is pretty much sealed well, and bone graft cannot escape from this socket. Okay, so I will skip the suturing video, and this is a post-operative x-ray to show nice sinus lift. CT scans always will show a black space between the bone and the implant, and this is just an artifact, so you don't need to worry about it. Here, just what I'm looking for is if there is any bone graft material above the Schneiderian membrane, and here we have a very nice, well-maintained bone graft plus nice implant location. So let me review my technique here that I presented. I presented two techniques here, lateral window and Crestal window. And let me compare that with other techniques out there. Both lateral window and Crestal window is not a blind technique. Therefore, if you have a perforation, you know that you have a perforation and you can manage appropriately. Versus osteotome technique or other Crestal approach out there, you know, it's a blind technique. So if you get a perforation, you do not know, and you might end up getting complications that I have shown at the beginning of this presentation. Not only that, I don't like to hammer people's head. and lead to benign vertigo. Therefore, I don't like using mallet. So I like to either open lateral window or Crestal window. But please bear in mind that lateral window, you will have higher morbidity. So appropriate training and appropriate diagnosis is very important prior to doing a lateral window technique. And also a Crestal window technique, you need specialized skill to do this, and you need specialized tools to achieve that. Therefore, I recommend to use Crestal window technique whenever you have a pretty wide reach, such as extraction socket. So when you compare to a conventional two-stage approach, you can save a lot of treatment time, and treatment time can be much less than conventional two-stage approach, and you can really avoid doing multiple surgeries to your patient. So I always recommend using Crestal window technique right after extraction and placing implant at the same time. So take-home message is that Crestal approach is less invasive than lateral approach, and I always use Crestal approach whenever possible, but minimal buccolingual dimension would be 9 millimeters. So when you have pretty brachyfacial and very wide bone, I recommend a Crestal approach. But if you have less than 9 millimeter width, then I recommend lateral window approach to make a predictable result, and I recommend using a very easy technique such as using my beer bottle opener concept. Thank you very much for listening to my webinar, and I will go into question and answer session. However, last time I did a webinar, we had a lot of questions, and we ran out of time. And I welcome anyone to email me if I don't get to your question. Please email me to samleedds@yahoo.com, and I'll be more than happy to answer your questions. We do offer 2-day hands-on courses, and next one is actually next week with Dr. Salama in Atlanta. However, that has been sold out due to high demand. So we are planning more courses next year in Boston and in Las Vegas. So I hope that you can join us next year. And I'm sorry that the next course in Atlanta is sold out. I appreciate your friendship all over the world, and it just impresses me every time I go to the conferences that just a simple screw such as a dental implant brings people all over the world and enjoy our profession. Thank you very much.
Well, you can see why I was so excited to have Dr. Lee present to you this evening on his new techniques for sinus augmentation. Very, very intriguing material, as I thought, and of course, beautifully documented. My compliments to Dr. Lee. We have quite a few people as well. You know, Dental XP is a global CE and educational concept. So we have a lot of people from all around the world. We have quite a few members from different parts of the world who have submitted some questions for you. And I'd like to just share those questions with you and sort of act as the mediator this evening. Dr. Lee, one of the questions that was written was from Europe, and they asked whether or not it's necessary to utilize a wide diameter implant in order to use your Crestal approach to the sinus.
That's an excellent question. In order to make a window through the crest, it will be much easier if we use wider diameter implants. The reason being is, bigger the window size, you will have a better visibility to the window. Therefore, I recommend personally minimum 4.5 millimeter diameter implant so that you can make minimum of 4.0 diameter window. Bigger it is, much easier.
I happen to agree with you. Having used your very technique, I could tell you that the utilization of wider implants, I'd even prefer 5 or greater, makes it a lot easier to get the instruments and access to the Schneiderian membrane. Does it affect the tension of the membrane as well with a bigger osteotomy? Does it affect the actual tension on the membrane as you start to lift it utilizing your instrumentation?
When you have a bigger osteotomy, you have a better access inside the sinus. Therefore, you will have a much less tension relieving the membrane.
And let me ask you, we're hearing more and more about utilizing balloons to help facilitate the lifting of the Schneiderian membrane. One of the questions that was written in actually from Taiwan asked whether or not after entering the sinus through the crest using your protocol, is it okay to utilize a balloon or one of the balloon concepts to then lift the Schneiderian membrane, and have you ever tried that?
I have tried a few times. I think it's an excellent idea to use the balloon technique after utilizing my diamond burr. However, I think it's really crucial to verify whether the perforation occurred or not after you use the balloon technique by asking the patient to breathe in and out and confirming that your membrane is intact. Personally, I do not use balloon regularly because I believe in manual manipulation of the instrument, and in presence of septum and irregular anatomical shape, balloon can actually lead to unwanted tear. Therefore, I believe in manual bone mapping with the Cobra instrument to know the anatomical features of the maxillary sinus. At the same time, I think it's a good idea to scrape the inner layer of the bone with the Cobra to promote bleeding, which cannot be done with the balloon itself.
Let me ask you, I have another question. People talk about the periosteum of the sinus having very high regenerative capabilities, and with the lateral approach, I know that we always want to lift the Schneiderian membrane to the medial wall of the sinus to expose as much of the periosteum as possible for regeneration. With the Crestal approach, we really can't get over to the medial wall of the sinus. How does that affect the timing of when you would come back and start to load the implants? Does it affect at all the healing phase?
That's an excellent question. When you have initial bone height less than 3 millimeter, in a sense, it becomes like a lateral window. Therefore, you have a full access throughout the sinus with my small instruments when you have initial bone height less than 3 millimeter. However, if you have more than 3 millimeter of bone height, it becomes a limitation in terms of getting access into a medial wall and the buccal wall and so on. Therefore, you have to rely on your bone graft material to elevate the membrane. Therefore, you would need to wait a little longer than usual.
Okay. And I happen to be a big fan, by the way. Your Cobra instruments are excellent to use. I've used them multiple times, and they're really very, very nicely designed. My compliments. I noticed that sometimes with a edentulous posterior maxilla, you've often utilized multiple Crestal approaches, and I thought that that was very clever. Would you ever suggest, and this is a question from Argentina, would you ever suggest doing multiple Crestal approaches, even if you weren't going to place the implants there, just to be able to get more access in your instruments, to be able to get elasticity and more of a lift of the sinus?
Yes, that's another excellent question. If the residual bone height is, again, less than 3 millimeter, I will attempt Crestal window whenever possible because I believe that it's minimally invasive compared to lateral approach. However, if I am putting implant at the same time, especially with the smaller diameter implant, I will do lateral window, elevate the whole maxillary sinus, and then put the implant.
And one of the questions that was asked, and this is a question from Egypt, the doctor asks, what happens and how do you manage the perforation if you're using a Crestal approach? Does it matter how large the perforation is? If it's only a few millimeters or if it's the entire size of the diameter of the osteotomy, how would you approach a perforation of those two dimensions, a small one or a very large perforation?
I'm a very conservative person, so if there is a small perforation, I feel safe to introduce the bone graft. However, if the perforation is larger than 3 or 4 millimeters, I will abort the procedure and then come back after the biology has repaired the Schneiderian membrane. The reason being is with Crestal window, you have a very small window size. Therefore, it is very difficult to repair the window. If there is any reason I need to finish the surgery in one procedure, I will open a much bigger lateral window than I do, and then repair the window with a collagen membrane after elevating with the lateral approach.
You know, I happen to be in agreement with you. I think when it's not just a millimeter or two, but if it is a millimeter or two, would you put a collagen or a fibrin membrane before you go ahead and initiate the repair or placing your graft, or would you just simply place the graft?
I believe in blood clot being the best glue and most easily accessible glue. But I believe that PRGF and PRF and all this biological fibrin that we have is also a very good idea. Personally, I just use blood clot.
Okay. And one of the questions in terms of a sloping sinus, let's say you had multiple posterior teeth that needed to be replaced and the sinus sloped, unlike a septum, but you had a sloping sinus where you went from 6 millimeters down to 2 millimeters on adjacent sites. Would you enter that kind of situation via Crestal approach, or would you just simply go in through a lateral approach?
I would simply go through a lateral approach.
I agree with you. I was wondering because when I was watching your presentation, I felt the same way, and I thought that that's what you would say. But I think it's a very important point that you have to understand the anatomy of the sinus. And are you using pretty much routinely CT scan technology to evaluate the sinus prior to grafting?
Yes. As I mentioned, when we take the CT scan, it's very crucial to make sure the sinus is healthy, and also make sure the natural osteum is patent so that patient can self-drain. And the third, we want to locate the location of intraosseous anastomosis of PSA. That will tell me where to make my lateral window if I'm going to lateral approach, or whether to do a Crestal window instead. And also, if there is any mucocele or polyp present, you want to make sure that will not block the natural osteum after the procedure.
Would you suggest to remove a mucocele before doing the sinus lift, or would you do it as a separate procedure, or same day, same time? What would you suggest?
If the mucocele is so large to the point where after I do my sinus elevation, if there is any chance that it will block the natural osteum, I will remove prior to the surgery by inserting a needle and aspirating through a small bone osteotomy. If the mucocele is not so big, I will, after I elevate my sinus membrane, I will insert small needle and then aspirate the liquid out of the mucocele.
Very, very good. I happen to be in agreement with you there. If you're going to puncture to gain access, would you make the puncture obviously through the Schneiderian membrane? But do you ever make an incision for a large mucocele to remove it, or you always try to use an aspirator?
Sometimes, I don't know whether Dr. Salama had the same experience, but once I had a huge mucocele on the panoramic, and I went inside the Schneiderian membrane. I ripped out the whole Schneiderian membrane searching for the mucocele, but I did not find anything. I think sometimes mucocele comes and goes in terms of size. How did you experience in your clinical?
I have seen that to be the case, but most of the time when I see it on the CT scan, I normally can find it. I sometimes have difficulty maybe at times getting it with an aspirator, so I may make a small incision and try to go and get it out either before the sinus lift. If it's in the same area, I will do it in stages, or if it's in a remote area, I would combine the procedures. Once again, I'd like to take this opportunity to thank Dr. Lee for sharing his knowledge and his modifications to sinus augmentation. It's really exciting to see people continue to alter and modify things that we've done, and to do it in such a well-organized and thoughtful way. Once again, Dr. Lee, our pleasure to have you this evening, and from Dental XP, myself, and for the audience all around the world. We have 5 continents and over 600 people here this evening. We thank you very, very much.